very pleased to be with you today to talk about the relationship between public health and Medicaid. After having worked for 3 years in Medicaid and 25 years in public health, I feel like I've learned a good bit about it. And I guess the key to understanding that relationship for me, particularly after having worked for 3 years at Medicaid, is that there's an awful lot of noise in Medicaid when it comes to a continuing parade of folks through Medicaid, all of them wanting something from them. And it builds a certain amount of, can build a certain amount of defensive shields that Medicaid people can have. Again, because of that sense, well, here comes yet another group, maybe public health, that wants something from us and have a solution that's going to cost us money. So it's a natural thing, and it would be unreasonable to think that that wouldn't happen. Well, how do you get past that? Well, one of the lessons that I learned over the years in public health is how important it is to, when you're working with Medicaid, not always going to them with a hand out, but to look for opportunities to help them. And the rule that we had in Alabama was there's only the rule when dealing with Medicaid is there's only one rule, which is the answer to every question or request that Medicaid makes is yes, and that we don't charge them for it. And that's just a stunning difference for Medicaid staff, Medicaid directors, to have someone to offer them something for nothing. I can give you some specific instances. 10 years ago or so, they wanted to put outstation eligibility workers in the community. We offered them space in the county health departments. We gave them the space. We didn't charge them for it. And they said, you mean we don't have to pay? No, we have the space. We're happy for y'all to use it. They went away happy. In fact, they went away both happy and honestly a little bit obligated. It made the next conversation about something that we needed a whole lot easier. And there were any number of opportunities like that. Data sharing. One of the best examples was Medicaid wanted our death files. In other words, people who have died in the last month, so that they could bounce that against their eligibility records. Medicaid, you see, doesn't want to pay Medicaid benefits for dead people, and that's a perfectly reasonable thing. Our vital statistics director had a problem with that. Not that we provide the data, but state law in Alabama required that the death record be paid for. Medicaid says we give you guys hundreds of millions of dollars a year and you won't let us bounce a record against. We're not asking for a printed copy of a death certificate. You won't go ahead and do that for us for free. And she rightfully said no, if you read the statute. Well, the way that we fixed that was the way we got to yes, which is the key. You know, the first answer may not be yes, period. It may be yes, and let's talk about how we can get this done. The way that we got it done was we said, okay, Medicaid can pay for the record, but we'll pay the state share. So it didn't really cost Medicaid anything from the standpoint of their state appropriation, which is the critical factor for them. So I guess to summarize, you don't want to go into a negotiation where you're always asking for something from someone else. You want to have built a relationship built on mutual advantage. And the thing that puts you at an advantage in working with Medicaid, who is a payor, and you who are a payee, is to be able to do things for them, particularly unexpected and without strings. I find that it puts you in a much better, or put us certainly in a much better position when it came to negotiating projects that were of interest and of need to public health. thank you for this opportunity to speak to you, and I wish you well in making your Medicaid deal.